Hi, thank you for attending my presentation for my research proposal on the effects of thiamine supplementation on lactate levels in critically ill adults. My name is Monica Moore. I'm a registered dietitian and a University of New England Master's Program candidate. In this presentation, we'll talk about some background, objectives, subjects for the study, research setting, methods and procedures, confidentiality, data analysis, and anticipated results and conclusions. Thiamine, also known as vitamin B1, is a water-soluble vitamin. It's in the bloodstream in very small stores and is affected by the systematic inflammatory response system, also known as SIRS. Because it's in the bloodstream in such small stores, deficiency is prevalent. Deficiency of thiamine can lead to Korsakoff syndrome, Wernicke's encephalopathy, and neurological issues. Additional symptoms could be things like falls, confusion, poor overall outcomes, and mortality. Sepsis is defined by characteristics such as systemic arterial hypotension, tissue hypoperfusion that comes along with organ dysfunction, and hyperlactatemia, which is high lactate levels. Newer definitions on sepsis include an even more sensitive serum lactate marker of over 2 millimoles per liter. Previously, it was over 4 millimoles per liter. Elevated lactate production and the reduction of clearance can worsen critically ill status and lead to these high lactate levels. Lactate levels have been shown to normalize with the recovery from septic shock. This shows the importance of lactate as a sepsis marker, as it tends to go up when sepsis is ongoing and tends to improve and go back down towards normal when sepsis is resolving. Mortality rates in sepsis are 28.3% in the United States and 41% in Europe. Sepsis also costs over $20 million for hospital-related care in the United States. When we look at thiamine and sepsis together, thiamine can act as a metabolic resuscitator and promote aerobic metabolism. This can lead to a decrease in lactate production and improve lactate levels back towards normal. Improving these lactate levels can lead to quicker sepsis resolution, which may lead to improved overall outcomes and mortality. Many studies have investigated this relationship and are continuing to investigate this relationship. However, there's a literature gap in dosing, timing, frequency of thiamine recommendations for sepsis. Recent studies have been inconsistent on their interventions and the effects of sepsis and critical illness. Higher prevalence of thiamine deficiency is also noted at hospital admissions than previously thought, again just fueling the need for studies around thiamine supplementation in the critically ill. Narrowing down recommendations of thiamine supplementation when and how to use it could improve overall outcomes, reduce mortality, and contribute to the standard of care in this population going forward. So with all that being said, objectives of this research proposal are to determine the effect of IV thiamine supplementation early in admission on serum lactate and thiamine levels in those critically ill hospitalized patients with sepsis. And a secondary outcome is to assess the prevalence of thiamine deficiency among critically ill at baseline when admitted to the hospital. The subjects will be over 18 years of age, have a diagnosis of sepsis or septic shock as determined by the hospital, including previous criteria points such as high lactate levels. They will have an anticipation of more than 24 hours of a hospital stay and will include both genders and all ethnicities. Exclusions will be under 18 years of age, prior thiamine supplementation either in the hospital or prior to admission, and end-of-life goals of care where the goals are more comfort-focused and not desiring aggressive interventions. Based on G-Power calculations, 176 participants will be needed, 88 participants in each group. The hospital will be the recruitment center for this study, and hospital admission will screen for the inclusion criteria to determine eligibility for the study. Informed consent will be obtained from either the patient or the power of attorney, dependent on the patient's ability to provide it themselves, and no additional compensation will be provided for participation in this study. The research setting will be Southern Maine Healthcare Hospital in Biddeford, Maine. As previously stated, consent will be obtained at admission when possible by the patient, if not by the power of attorney. Clinical staff will perform interventions and collect data to give to the researcher, and electronic medical records will additionally be used for data collection and intervention administration tracking. Southern Maine Healthcare uses Epic as their electronic medical records system. It will be a randomized controlled trial, although not blinded. Subjects will be randomized into either the intervention or the control groups at inclusion. The intervention group will receive IV thiamine, 200 milligrams within the first 24 hours of admission, and then 100 milligrams IV daily thereafter. The control group will receive no supplementation or placebo, which is why it will not be blinded, as the clinical staff will know whether they are giving something or giving nothing, as will the patient potentially. Interventions will continue until discharge or until 7 days has passed, whichever comes first. Each patient will be coded with a number at inclusion. This will not only ensure confidentiality, as I'll discuss in a minute, but also for data administration and for giving information to the researcher. Labs will be checked at admission and daily thereafter for serum thiamine and serum lactate levels, which will be added to existing daily lab draws, so no additional lab draws or poking or prodding will be needed. Administration of thiamine will be documented in the chart flow sheets. Data and intervention administration information will be collected by the clinical staff and sent to the researcher via email using the number-coded system. The researcher will keep the spreadsheet with all the data. Patients' personal identification information will not be shared with anyone, including the researcher, to assure confidentiality. Additionally, patients will be coded with a number at inclusion, as reported previously, and the researcher will not have access to the electronic medical record. The spreadsheet with the data will be kept on a password-protected laptop, only accessed by the researcher, and only medical information or data that is pertinent to the study will be shared with the researcher by clinical staff. Consent forms that are done at admission and inclusion to the study will be kept in the patient's chart, and the patient's chart as a whole will be protected by HIPAA. For data analysis, since quantitative data will be being collected, an independent t-test will be used for the significance between means of each outcome, the serum thiamine and the serum lactate, at start and finish of the study. The null hypothesis will be considered rejected if the p-value is less than or equal to 0.05. Graphs will be made to illustrate the difference in outcome means between thiamine and control groups, and a pie chart to illustrate the percentage of participants with thiamine deficiency at admission will also be created. Comparing risks versus benefits, there is no more than the minimal risk involved in participating in this study, and potential benefits could be improved overall health outcome, quicker improvement of sepsis, decreased hospital complications, decreased hospitalization length of stay, decreased time on mechanical ventilation or vasopressor support, and improved thiamine levels. Anticipated results of the study are an increase in serum thiamine levels from start to finish in the thiamine supplemented group, and a significant difference compared to the control group in improvement in thiamine from start to finish. This is demonstrated on the graph to the right. Another anticipated result is a decrease in serum lactate in the thiamine supplemented group from start to finish, and a significant difference between thiamine group and control group in lactate reduction over time, as demonstrated on the graph to the left. Additionally, the percentage of critically ill patients at admission with baseline thiamine deficiency will be found and charted. The conclusions are to be determined. I have no conflicts of interest to disclose. There's no funding or financial disclosures to report, and this proposal was submitted for IRB approval through the University of New England in June of 2020. Does anybody have any questions? While you're thinking about questions, here are the references. Thank you for listening to my proposal today.